My nursing presentation, neuro ICU acuity-based staffing and staff support. So the introduction to the problem. The neuro ICU presents a highly demanding environment where critically ill neurological patients require timely and complex assessments. Fixed nurse to patient ratios often fail to reflect patient acuity, resulting in workload imbalances and increased risk for missed neurological assessments. When assessments are delayed or missed, patient deterioration can go undetected, increasing morbidity and mortality. Concurrently, ICU nurses face significant cognitive and emotional demands, contributing to higher burnout and turnover rates compared with other specialties. These challenges affect patient safety, nurse satisfaction, and team stability. Addressing these issues require a dynamic staffing model that adjusts emotional exhaustion and maintain workforce resilience. This forms the foundation of the capstone project. My next topic is the rationale for the selection. The rationale for the selection of this project stems from both empirical evidence and observed clinical needs. Research indicates that fixed staffing ratios often do not align with the fluctuating demands of critically ill neurological patients, which can increase the misassessment and have adverse outcomes. Burnout among ICU nurses is consistently higher than in other specialties due to cognitive and overload and emotional strain, leading to increased burnout and turnover rates. By implementing an acuity-based staffing model with structured staff support, the project addresses workforce sustainability while improving patient safety. Enhancing nurses' well-being through peer support, mindfulness, and debriefing interventions will not only benefit staff but improve the patient outcomes, as healthier, less fatigued nurses are better able to provide timely and accurate neurological care. So my pick a question for this project is neuro ICU patients, based on neuro ICU patients, the acuity of the staff and support, and against fixed nurses to patient ratios, missed assessment, burnout, turnover over a period of 6 months. This guiding question comes from how does implementing an acuity-based staffing model combined with structured staff support interventions combined with fixed nurse-to-patient ratio staffing affect rates of missed neurological assessments, nurse burnout, and turnover over 6 months. This question reflects a dual focus on patient safety and workforce sustainability, highlighting the need to address both clinical and human factors in high acuity environments such as the ICU. By explicitly defining the population, intervention, comparison, outcome, and time frame, the Pickett framework ensures the project is evidence-driven and measurable. This structured approach also guides methodology, implementation, and evaluation, ensuring each component of the project is aligned with clearly defined objectives and expected outcomes. So, literature review summary. The literature review revealed consistent support for acuity-based staffing and structured staff support, improving outcomes in high acuity environments. Acuity-based staffing allows workforce workload to match patient complexity, reducing misassessment and improving patient safety. Additionally, structured support interventions such as debriefing and peer validation mitigate burnout, enhance resilience, and improve retention. Evidence from multiple studies shows the combining staffing intervention with wellness initiatives not only benefits nurses but also positively impacts patient outcomes. However, some studies have highlighted barriers such as staff resistance and implementation complexity. Overall, the literature strongly supports using evidence-based quality improvement strategies, making this approach both feasible and justified for the neuro ICU setting. Literature critique. While the literature supports the acuity-based staffing and staff support interventions, there are limitations within the model. Many studies differ in design, sample size, and setting, which can affect the generalizability. Research specifically targeting neuro ICUs is relatively sparse, making exploitation necessary but cautious. Despite these limitations, there is a strong consensus that staffing models aligned with patient acuity improve clinical outcomes and structured support reduces burnout and turnovers. Critically evaluating the literature revealed that while methodologies vary, the practical application of these strategies in high acuity settings demonstrate consistent benefits. This critical analysis reinforced the decision to adopt an evidence-based approach integrating both staffing and staff wellness strategies. So quality improvement model. The project integrates multiple quality improvement models to ensure successful implementation. We have the Plan, Do, Study, Act PDSA cycle that provides a framework for iterative testing, allowing the team to make incremental adjustments based on real-time feedback and performance data. Coda's 8-step change model supports adaptation by creating urgency, forming coalitions, communicating the vision, and reinforcing change through early wins. Using this model helps address staff resistance and ensures cultural integration of the intervention. Squire 2.0 reporting principles guide transparent documentation of context, intervention rationale, methods, and outcomes, ensuring replicability and validity. Together, these models all provide a robust structure for managing change, improving nurse adherence to acuity-based staffing, supporting staff well-being, and evaluating outcomes in a systemic, evidence-based manner. Methodology overview is my next section. So the project uses a mixed methods approach to capture both measurable outcomes and contextual insights. Quantitative data will be collected through electronic health records audits to track missed neurological assessments, the MASLAC burnout inventory to assess nurse emotional exhaustion and resilience, and HR reports to monitor turnover. Qualitative data will be gathered via semi-structured interviews and focus groups to understand the staff perception regarding the workloads, support, and unit culture. Combining these approaches allows for triangulation, enhancing validity, and providing a holistic view of intervention impact. This methodology aligns with quality improvement principles and evidence-based practices, offering actionable insights while highlighting areas for adjustments, reinforcement, and workforce outcomes within the neuro ICU setting. Implementation plan overview. We have structures of phases to ensure systemic adaptation. Phase 1 involves collecting baseline data over 4 weeks, including missed neurological assessments, nurse burnouts, and turnover rates. This provides metrics for comparison. Phase 2 spans over weeks 5 through 12 and focuses on selecting and training nurse champions who serve as role models, facilitators, and advocates for the intervention. They will receive training on acuity-based staffing, tools, and communication strategies. Phase 3 involves the phased introduction of the full intervention over months 3 through 6. This includes integrating the acuity tool into daily staffing huddles and implementing structured staff support interventions, such as mindfulness, breaks, peer reviews, and your unit-based council meetings. Progress will be monitored via chart audits, attendance logs, surveys, and unit feedbacks, allowing iterative adjustments to be made. Next, we have implementation objectives. The project objectives are SMART, which stands for specific, measurable, achievable, relevant, and time-bound. The first objective is achieving at least 90% compliance with the acuity-based staffing tool during the shift assignments within 12 weeks. The second objective is a 30% reduction in missed neurological assessments over 6 months, measured through the EHR audits. The third objective targets at least 70% participation in structured staff support interventions, including mindfulness and peer debrief sessions within that 4-month period. Finally, the project aims for a 10% reduction in nurse turnover within 6 months. This will be tracked using HR retention data. These objectives are aligned with both patient safety and workforce sustainability goals, providing measurable outcomes to evaluate the effectiveness of the intervention. We have the evaluation plan. The evaluation plan relies on the PDSA cycle that I spoke about to monitor implementation, identify barriers, and iteratively refine the intervention. Quantitative data include EHR audits of neurological assessments, acuity tool compliance metrics. We have mass lax burnout inventory scores and the HR turnover data. The qualitative data are obtained through staff interviews and focus groups to capture perceptions of workload support and culture change. Benchmark comparisons will be used to assess progress, including expected reductions in missed assessments, burnouts, and turnover, and target participation throughout the program. This approach allows continuous monitoring of both clinical and workforce outcomes, ensuring timely adjustments. Triangulating multiple data sources enhances the validity and reliability of findings, supporting evidence-based conclusion and future sustainability. So evaluating these benchmarks, because of the ability to provide measurable goals based on the literature and best practices, acuity tool compliance should reach 80 to 90% to ensure staffing reflects patient needs effectively. The missed neurological assessments will be targeted to decrease by 20 to 30% over the 6 months, improving patient safety. Burnout reduction benchmarks aim for 10 to 20% reduction in emotional exhaustion scores, enhancing nurses' well-being and resilience. Staff participation in structured support programs and debriefing sessions is targeted at 60 to 70% to ensure adequate engagement and effectiveness. These benchmarks are evidence-based, providing realistic, attainable goals that allow for monitoring progress and adjusting intervention through the PDSA cycles, supporting the dual objectives of workforce sustainability and the patient safety. So data collection methods, combined with qualitative and quantitative methods. EHR audit provides objective, time-stamped data on neurological assessment completion, ensuring accuracy and consistency. The Maslach Burnout Inventory, or MBI, is a validated instrument that assesses emotional exhaustion, depersonalization, and personal accomplishment among nurses. HR turnover data offers standardized organizational metrics on staff retention. Qualitative insights are gathered through semi-structured interviews and focus groups, allowing staff to share their perception regarding the workload and their unit culture. Combining these methods allows for improvement, reliability, and validity. This comprehensive approach ensures both clinical outcomes and workforce experience are captured, informing iterative improvements and supporting the evidence-based practice decision that we need in the neuro ICU setting. So sustainability strategies. Sustainability is essential for lasting practice change. First, embedding the acuity-based model tool into daily huddles ensure consistent use, reinforces habit formation, and aligns staff with patient acuity. Second, the nurse champions provide ongoing peer support, coaching, and reinforcement of best practices, serving as role models and helping staff to adapt and maintain new workflow. Third, quarterly audits and real-time feedback keep staff informed about performance metrics such as compliance with assessments, burnout scores, and participation in support programs. And finally, integrating the staffing and support intervention into a formal hospital policy ensures the intervention is institutionalized and continues beyond the initial project timeline. Together, these strategies promote long-term adherence, reinforce the value of evidence-based practice, and maintain improvement in patient safety and nurse well-being. So let's talk about the role of the champion. So the role of the champion is a critical role for implementation and dissemination. They lead education sessions, in-services, and training to ensure nurses understand the acuity-based staffing tool and staff support interventions. Champions monitor adherence, providing real-time coaching and reinforcement to maintain compliance and correct workflow errors. They serve as mentors, supporting staff emotionally and professionally, which fosters engagement and resilience. Additionally, they act as a liaison between bedside nurses and leadership, communicating challenges, successes, and feedback to ensure alignment with organizational goals. Research has showed that having a dedicated champion increases adoption rates, reduces resistance, and sustains change over time. In this project, the champion ensures that both clinical outcomes and staff well-being are continuously prioritized, reinforcing evidence-based practice as part of the unit's culture. So next we will look at dissemination overview. So the dissemination overview, give me a second, ensures evidence translates into practice. Internally, a structured form such as in-services, unit-based council meetings, and interdisciplinary rounds allow for staff to learn about the project, ask questions, and understand its relevance to patient safety and nurses' well-being. Visual tools, including posters and quick reference cards, reinforce practice changes and serve as continuous reminders, especially in high acuity, fast-paced environments at the neuro ICU. Digital tools such as intranet postings and recorded presentations expand access to night shift, weekend, and per diem nurses, supporting asynchronous learning. Externally, dissemination involves manuscript preparation for peer-reviewed journals and presentation at national conferences like the American Association of Critical Care Nurses or the American Association of Neuroscience Nurses. These strategies share knowledge with the broader nursing community, foster networking, and contribute to national discussions and acuity-based staffing and burnout reduction, ensuring findings have both local and widespread impact. So the next topic we have is the internal dissemination strategies, because we'll go through internal and external. So internal dissemination focuses on ensuring that all neuro ICU staff understand and adopt the intervention. Unit-based in-services and workshops provide structured opportunities to present evidence, explain intervention rationale, and demonstrate the acuity-based staffing tool. Staff huddles and interdisciplinary rounds allow real-time discussion of patient needs, workflow adjustments, and support program participation. Regular updates and refresher education sessions reinforce learning, address concerns, and highlight successes to maintain engagement. These strategies promote collaborative learning, build unit culture, and facilitate consistent use of evidence-based practices. By engaging staff in multiple repeated ways, the project ensures comprehension, fosters participation, and improves the likelihood that it will be long-term adopted. So visual and digital tools. Dissemination strategies help maintain awareness and accessibility of evidence-based interventions. So as we mentioned, posters placed in staff areas such as workrooms, break rooms, and charting station act as continuous reminders of the project's goals, workflow changes, and expected outcomes. Laminated bedside reference cards summarize acuity tiers, neurological assessment schedules, and key staff support resources providing quick action information during the busy shifts. This is exactly the kind of tool that will be needed for staff that float to units such as the neuro ICU that are not regular staff, because this will keep them up to date on our regular practices while providing patient care. Digital strategies include intranet posting with evidence summaries, intervention tools, and short narrative slide decks, which accommodate diverse learning styles and allow for asynchronous access for staff who cannot attend live sessions. Together, these strategies reinforce consistent use of the acuity tool and staff support interventions, normalizing evidence-based practice and improve knowledge retention, which ultimately promotes sustainable improvement in patient care and the nurse's well-being. Now for the external dissemination. External dissemination extends the impact of the project beyond the neuro ICU. Preparing manuscripts for submission to peer-reviewed journals such as the Nurse Leader or Nursing Forum allows the finding to contribute to a wider nursing evidence base and inform practice in similar high acuity settings. Abstracts submitted to the national conferences such as the American Association of Critical Nursing and Neuroscience Nurses provide opportunities to share outcomes with experts, gain feedback, and enhance professional visibility. Presenting findings through posters and podium presentation fosters networking, collaboration, and knowledge exchange. External dissemination not only validates the project methods and outcomes, but also encourages adoption of evidence-based staffing models in other institutions, contributing to a national dialogue on improving patient safety and reducing nurse burnout in ICUs overall over the country. So staff engagement. Engaging staff is essential for successful implementation and sustainability. Regular feedback sessions share performance metrics such as acuity tool compliance, missed assessment, and staff well-being scores, allowing nurses to see the tangible impact of their efforts. Recognizing early successes through celebrations, awards, or public acknowledgement reinforces positive feedbacks and promotes continued participation. Encouraging staff ownership in intervention decisions, such as scheduling mindful sessions or peer support initiatives, fosters a sense of agency and accountability. High levels of engagement improve adherence to practice changes and reduce resistance and encourage unit culture. So the project outcomes. The anticipated outcomes of this project, as we said, are measurable and tied to both clinical and workforce goals. I expect increased compliance with the acuity-based staffing tool, which will ensure that workload aligns with patient needs, improve patient safety, and missed neurological assessment are expected to decrease significantly. Have we followed the model as is? Improved nurse well-being is measured using MASLAC burnout inventory scores, reflecting reduction in emotional exhaustion and enhanced resilience. Structured staff support programs continue to higher engagement, satisfaction, and retention. As a result, turnover rates are expected to decline, stabilizing the workforce and enhancing continuity of care. My challenges and barriers. Several challenges may arise during implementation. Staff resistance is common with workflow challenges and changes, particularly if nurses feel additional responsibilities or disruption to established routines. The neuro ICU's high patient acuity and variable workload may make consistent use of the acuity tool challenge. Time constraints may limit participation in staff support interventions such as mindful sessions or debriefing, particularly on night and weekend shifts. Data collection may be impacted by incomplete documentation, variations in charting practices, or inconsistent survey completions. So from this proposal presentation, lessons that I've learned, several lessons emerged that are critical for success. Strong leadership support is essential for securing resources, reinforcing priorities, and legitimizing practice changes. Nurse champions are invaluable in modeling behaviors, mentoring colleagues, and maintaining engagement, particularly in complex high acuity environments, such as the neuro ICU. Actively incorporating staff feedback ensures the intervention addresses practical challenges and enhances buy-in. These lessons highlight that successful quality improvement projects depend on collaboration, communication, and adaptability. So in conclusion, implementing an acuity-based staffing model combined with structured staff support in the neuro ICU addresses critical challenges in patient safety, nurse burnout, and turnover. Utilizing PDSA cycles and the CODA's 8-step change model provides a structured framework for planning, implementing, and sustaining change, allowing iterative adjustments and fostering unit culture adoption. Evaluating using quantitative and qualitative measures ensures interventions are effective, progress is measurable, and benchmarks are met. Dissemination strategies, both internal and external, reinforce learning, promote engagement, and extend the project's impact beyond just the neuro ICU unit. By integrating evidence-based practice into staffing decisions and workforce support, this project demonstrates that thoughtful, systemic quality improvement can enhance patient outcomes, support nurses' well-being, and strengthen the overall healthcare system by providing a model for other high acuity units. This is my reference pages. I have about 17 references, including peer reviews and the courses books, and that's all that I have to share. Thank you so much for listening to my presentation.